Our today's topic is diabetes mellitus in pregnancy. Let's focus on the scenario first. They might mention a diabetic woman or an episode of glycosuria in the mother, or in the fetus they might mention fetal macrosomia or polyhydramnios. They can also give the history of a previous stillbirth. All these points will direct you towards diabetes scenario. Let's see who is at the risk of getting diabetes. If your parents have diabetes, you are at the risk of getting diabetes too. Family history is a strong risk factor. If you are obese, there might be an insulin resistance which can lead you to diabetes. And if in your previous pregnancy you had a stillbirth or polyhydramnios or congenital abnormalities, you are more prone to getting diabetes mellitus in your next pregnancy. But why is diabetes such a big concern? Well, if you look into the detail of the complications that occur in the mother, fetus, and in the neonate, you will understand it. Let's look at the maternal complications first. Let's say your patient was pregnant and is just diagnosed with diabetes mellitus. As her doctor, what complications should you keep in mind? First of all, if she is diabetic, she is at increased risk of getting diabetic ketoacidosis. And in the long run, diabetes also affects your blood vessels. It causes microangiopathy. So if blood vessels are getting affected, she is more prone to getting hypertensive disorders too, like preeclampsia. So you'll have to keep a check and balance on her BP. There is also an increased risk of getting infections. Remember Candida albicans? One of the risk factors was the diabetic woman. You can remember the increased risk of miscarriage by keeping in mind the infections. If she's more prone to getting infections can lead to miscarriage. And as the babies of the diabetic women are oversized, they have macrosomia, so the operative delivery rate is definitely increased. So the maternal complications are DKA, preeclampsia, infection, miscarriage, and operative delivery. Let's take a look at the fetal complications. Definitely fetus is at the more risk of macrosomia. Macrosomia means the size of the baby is larger than normal. Oversized baby. And remember, we linked macrosomia in shoulder dystocia too. Because the baby was oversized, he was going to get stuck at the level of his shoulders during the delivery. Next complication is intrauterine growth restriction. But how? Remember that blood vessels are going to get affected in diabetes, including the placental blood vessels too. So the exchange of the oxygen and other contents of the blood is going to get interrupted. How can diabetes cause neural tube defects, cardiac anomalies, and congenital defects? Well, the hyperglycemia is going to cause the oxidative stress, which will lead to alteration in the genes and ultimately affect the neural tube, the heart, and cause other congenital defects. As diabetes is going to affect the fetus even at the genes and placenta level, so there is definitely increased risk of stillbirth. And lastly, hyperglycemia and hypoglycemia. As the mother's blood is hyperglycemic, so baby will receive the hyperglycemic blood and is more exposed to getting hyperglycemia. Or in the long run, the pancreas of the baby will produce more insulin through hyperplasia to balance out this hyperglycemia, and more insulin will be produced, so baby can get hypoglycemia in this case. Now let's look at the neonatal complications, DKA, trauma, birth asphyxia. As the baby is oversized, so during vaginal delivery, birth asphyxia can occur. And hyperglycemia can cause jaundice and polyhydramnios too. After the birth, as the baby is no more connected to mother through placenta, so there won't be hyperglycemic blood, but the previous hyperplasia of the pancreatic beta cells will continue to produce more insulin, which will lead to hypoglycemia in the neonate. And as you might need to deliver these babies a bit earlier due to complications like preeclampsia. The fetal lungs might be compromised and can lead to neonatal respiratory distress syndrome (RDS). So let's say your patient had 2 episodes of glycosuria and has a history of previous stillbirth. So, what investigations should be carried out to confirm your diagnosis about diabetes? Well, CBC, RFTs as it is going to affect the renal more, blood sugar random, blood sugar fasting, glucose tolerance test, HbA1c. All of these make sense. But why ultrasound? Well, the ultrasound is important to check for the cardiac anomalies and other congenital anomalies and to check the fetal growth as there was a complication of fetal growth restriction. When it comes to the preconception counseling of a non-diabetic woman, you should tell her about all the risks and complications to mother and fetus, advise her folic acid 5 mg preconception to avoid the neural tube defects, and she should control the glycemic index at an optimum level to prevent the hyper and hypoglycemia. You should assess her HbA1c before conception. Tell her about all the risk of congenital abnormalities, and genetic counseling should also be done. And if there are any previously used drugs that are teratogenic, you should replace those drugs. You should also counsel her about the likelihood of prolonged admission or early delivery, and the possibility of accelerated maternal retinopathy and decline in the maternal renal function if her retinas and kidneys are already affected. When it comes to management, this is the most important part as you can prevent so many complications by managing this case properly. Control the glycemic index with diet first and then with insulin. Weight control, as obesity was also a risk factor. Renal and retinal screening, prevent hypo or hyperglycemia, and anomaly scan at 20 weeks to monitor the cardiac outflow. Fetal echocardiography, as the fetus is at the risk of cardiac anomalies, and plan the vaginal delivery at 38 to 39 weeks, or if there are complications like preeclampsia or macrosomia, then you should plan the C-section. I have added this new slide from the UWORLD notes and AMBOSS notes about diabetes mellitus and not about gestational diabetes mellitus. If someone has diabetes before pregnancy, her HbA1c value should be kept less than 7%, and go for the diet and exercise first to control the diabetes and then medications. Now, if she wants to get pregnant, change the oral medication to insulin. Now, when this diabetic woman got pregnant, her insulin requirement is increased, and you should try to keep her postprandial sugar less than 180. During the delivery, give her a dose of betamethasone for the lung maturity of the fetus, that is a steroid. And after pregnancy, there should be a massive reduction in the insulin. And lastly, the uncontrolled diabetes mellitus leads to an increased risk of congenital anomalies. Take a look at the past paper scenarios, and that's all for today.